Okay, I think the clock has struck 7 on my computer, so we may get started if that's all right. I'm sure there'll be lots of other people who will join in a few minutes, which is fine. Welcome, everyone. So hello and welcome, and thank you again for joining us on a Tuesday evening, after work or whatever it is that you've been doing with your days. So I just to do some introductions, I suppose. I am Dr. Sarah Appleton. So I'm a highly specialist clinical psychologist working in obesity and weight management at Guy's and St Thomas's Hospital. So I actually work with Alastair or Al in the South East London Healthy Weight Programme. And I also work as a clinical and care professional lead for Partnerships Southwark. And I love my job, I think, because I get to move away from the kind of simplistic narrative that can surround weight about needing to just move more and eat less, and actually really explore the complexities in terms of, the role that our biology, our psychology, and our social environment plays in managing our weight. So it's a pleasure to be talking about obesity and mental health. This is an issue that is very close to my heart, and particularly talking about the research in this area, as I know how important that is. It's also a pleasure to be joined by my colleague, Dr. Alastair Duncan, who will be our expert guest for the webinar this evening. So Al, do you want to introduce yourself?
Please call me Al, as Sarah says. Welcome to everyone. I know people joining as we speak, and that's absolutely fine. So I'm a consultant dietitian. I work at Guy's and St Thomas's NHS Foundation Trust in central London. And I've been working there for the last 26 years. And like Sarah, I absolutely love my job. Now, we've received so many questions in advance of this evening's session, and thank you for sending those in. But you are also able to ask questions during this evening's event. So please post them in the Q&A box. So not the chat, in the Q&A box if you have questions as we go along. So the Q&A box is the little speech bubble, and depending on your settings, it's going to be at the top or the bottom of your screen. And we'll do our best to answer those questions. If they're similar to ones that have already been asked prior to the event, then we'll just slot them in at that point along with a theme. So everyone, please ensure your camera and microphone are turned off. Again, it's the buttons at the top or bottom of your screen, depending on your settings. Now, I'm not going to be able to answer any personal questions you have about your own health or individual cases of patients that you may be looking after. So if you have any questions about your own health, please ask a healthcare professional if you have any concerns. Tonight's webinar is being recorded, as you can see, and you'll be sent a link to the recording, which will be uploaded on the NIHR's YouTube channel. So the NIHR has organised this event. And as you're probably all aware, the NIHR is a government-funded body. It funds research in the NHS, public health and social care. And I'm very privileged to have been funded with an NIHR research fellowship, which enabled me to conduct a portfolio of research studies investigating prevention of diabetes, weight management, body image, mental health. So I'm very privileged to have had that funding from the NIHR in the past. Now, if you're interested in learning more about research and searching for studies that you could take part in, for example, please visit the Be Part of Research website. All you need to do is put Be Part of Research into any search engine and it will come up. Remember, you can take part in many studies, and even if you don't have a particular health condition, you can take part. So, for example, I took part in a research study myself that was funded by the NIHR, and I was a kind of healthy volunteer to be compared against people who were living with a long-term health condition that I don't have. And I really enjoyed taking part in that. So I would encourage you to think, if you fancy taking part in some research, it can be very interesting. That's enough of the blurb from me. I'm going to hand over to Sarah.
Perfect. Thank you, Al. So yeah, as you said, we have been inundated with questions beforehand, which was great. Lots of excellent questions. And to try and make sure that we sort of speak to the areas that feel important, Al and I have kind of gone through, haven't we, and grouped the questions into different themes. So for example, we have themes on obesity and mental health, or pharmacotherapy, something that's coming up a lot nowadays, weight stigma, and several other areas. So we'll try and kind of work through those areas, just asking different questions as we go along. But I'm also aware that we only have the hour, so we'll see how far we get through and try to pull in some questions from the chat. But obviously, if there are any questions that you can't get to, we have agreed, I think, Al, that you will kind of go through and answer some of those questions after the session, and that those answers will get circulated. Was that right?
I'll do my best with that. Yeah, and
Perfect.
we'll also circulate any references to studies that are mentioned during the webinar as well.
Fantastic. Okay, so should we get started with some questions?
Sure.
You're sitting comfortably, Al. Perfect.
I'm sitting
Right.
uncomfortably, yes.
Perfect. So the first theme we agreed on was the kind of relationship between obesity and mental health, quite broadly. So just to start off by exploring the relationship between excess weight and mental health. And the first question was, are sort of adverse mental health and excess weight issues that should be treated separately, or can they be looked at more holistically together?
Thanks, Sarah. So just before I go into this question, I know people are still arriving in the webinar, so just welcome to everyone who's arrived recently. My name's Al Duncan. I'm consultant dietitian at Guy's and St Thomas's, and I'll try and answer these questions as best I can. If you have any other questions, those who've recently joined, you can put them into the Q&A, so not into the chat, but into the Q&A box. So thanks, Sarah. So the question you asked was, should adverse mental health and excess weight be treated separately or holistically? So I'm a firm believer in them being treated together in a holistic way, although there are cases when that may not be the best course of action, and I'll try to explain that a little. There's a very complex relationship between adverse mental health and excess weight, and a lot of this pivots around stigma. So stigma for both mental health and for excess weight. And as I said, the treatment probably in most cases should be holistic, so for both at the same time, but this definitely needs to be individualized. So what we've seen in clinical care, not just at Guy's and St Thomas's where I work, but across the country and globally, is that the best outcomes occur when care is individualized. So, for example, at Guy's and St Thomas's, we have a wide range of weight management interventions, including bariatric surgery. And it might be, for example, for one person, that their mental health should be optimized prior to having the surgery itself. And we have psychologists who work in our bariatric team who work towards that goal, supporting people living with adverse mental health. But then in other situations, it might be better to move to the bariatric surgery more rapidly. For example, if somebody has, life-threatening metabolic complications, so that might take priority. So, as I said, probably individualizing the care is the most important thing. But holistic simultaneous treatment is better for most people. And I guess we'll look at a lot of this, particularly around stigma and so on, in more detail as we go through this evening.
Absolutely. I completely agree. I think that actually answers another question we had of, if treated separately, which is better to treat first? Actually, you kind of touched upon that there, of just needing to do that on an individual basis, I think, based upon the needs and the kind of risk stratification by the sounds of it.
That's right. Yeah, thank you.
Okay. So another question is, do people living with excess weight always experience difficulties with their mental health?
Well, the short answer is no. But there's a whole range of studies and meta-analyses. Those are where you bring results from many studies together that show that people living with a heavier weight usually have a higher incidence of experiencing adverse mental health. So, for example, there was a study I remember from the United States where they measured that 60% of people living with a heavier weight had experienced some type of mental ill health in the previous 12 months before starting on their weight management intervention. And again, if we think about bariatric surgery that I was just talking about, so we've seen that about 1/3 of people proceeding to bariatric surgery have reported significant symptoms of depression prior to the surgery, and that study was from the United Kingdom. And then thinking about some of the cohort studies, so these are the ones where we look across a range of people who are at a point in time, and we've seen that people living with the highest level of excess weight are 5 times more likely to experience depression compared to matched people with an average weight. So in that study from the United States, what they did was they matched people according to age, gender, ethnicity, and socioeconomic status. Yeah, and they found that even with matching them, that people with the highest excess weight had significantly higher likelihood of experiencing significant depression.
Okay, thank you, Al. Does one generally come before the other? So, i.e., does living with excess weight impact upon mental health, or does mental health kind of impact upon an individual's weight? So, just thinking about the causality, cause or consequence there.
Okay, so I think there's definitely a bi-directional relationship. And from what I remember from studies, it's equal. So, for example, with depression, the risk for, if you have depression, the risk for then gaining weight and experiencing excess weight is twofold. If you have excess weight, then the risk for developing depression is twofold. And I think that risk is slightly higher for women than men, studies suggest. And if we think about, for example, anxiety rather than depression, it's also bidirectional each way, but slightly less, so about a 40% increased chance of developing one following the other. Yeah, so it's chicken or egg. It's difficult to answer exactly, apart from the way that I just described with those studies. But for example, let's think about somebody who's living with a serious mental illness. They're much more likely to be sedentary. So there's studies that have demonstrated that quite clearly. And then perhaps that might lead to a more likelihood of gaining excess weight at that stage.
Absolutely. I think it makes sense, doesn't it, in terms of if somebody's struggling with agoraphobia or difficulties, with anxiety, it's going to be so hard to go outside, to go food shopping, to go to the gym, to do all of those kind of things. Similarly, if someone's experiencing difficulties with low mood, that's going to really impact upon, just feeling tired or exhausted or planning meals or all of those other kind of things.
Yeah, thanks, Sarah.
No problem. Okay. And is there an impact of adverse childhood events on weight in later life?
Yes, yes, definitely. So this is one of the areas where there have been some really good systematic reviews. And so for those of you not familiar, so a systematic review is where the researcher looks at related studies from all over the world investigating the same topic of interest. And the one that I'm thinking of was conducted in the University of California in Los Angeles, and they trawled through all the databases to find studies that had looked at any links between adverse childhood events and weight later in life. In the end, they found 18 high quality studies, and they showed that when they combined all of the data from those 18 studies into one, that there was a 46% increased risk of excess weight in adulthood for people who had experienced adverse childhood events. And they proposed that the mechanisms for this happening are for example, chronic stress in response to trauma in childhood and social disruption in adulthood.
Absolutely. Thank you, Al. The next kind of sections we're going to move on to, and again, this is sort of rapidly moving through these kind of different questions, but is just a short question actually on disordered eating that came up. So, are people who successfully lose weight more likely to experience an eating disorder such as anorexia or bulimia nervosa?
Okay, thank you. So this is people who have lost weight successfully, so been treated for that or taken part in an intervention,
Mm-hmm.
and then subsequently, are they more likely to experience disordered eating, such as anorexia or bulimia. Just before I come on to that, I've realized that quite a few people have joined in the last few minutes. So just to say, if you have any other questions in addition to what we're talking about, please pop them in the Q&A. So not in the chat, but in the Q&A, and we'll try and answer them as well as we go along. So thinking about development of anorexia or bulimia nervosa following successful weight loss, it's an interesting question that's been posed here. And I've been thinking about this actually over the course of today. So let me just take you through some studies that have looked at this. So there was a study which was published in 2015, which was from Southeast London, from my colleagues at King's College University, where I work part of the time. In this study, they took a sample of, I think it was almost 2,000 people from the local Southeast London population, and using questionnaires explored the incidence of disordered eating. They found that, so this is the general population in Southeast London, they found that 4% of people had binge eating disorder, 2% had either anorexia or bulimia nervosa combined, and 1% displayed purging behavior. So for example, using laxatives to lose weight. And out of all of these people, that study also showed that only 1 in 7 had received any treatment for those conditions, which was, really quite shocking when I was looking at that. So we know that disordered eating is much more common in people living with a heavier weight. So, for example, emotional eating is very common, binge eating disorder already mentioned. But the question was specifically about, are people likely to develop these conditions following successful weight loss? Well, I guess the mechanism might be if you are struggling to meet your weight loss goals during an intervention, that could lead to behaviors such as purging during that intervention, and they may not be observed by the people supporting you in that intervention. But there's some other studies. So from the United States, so anorexia and bulimic behaviors were observed at an equal rate amongst young adults who had always had an average weight compared to those who were heavier and had successfully lost weight. So in that study, there was no suggestion that this was a phenomenon. But at Guy's and St Thomas's, actually, it's not myself, but it's my colleague Sarah Appleton who's asking the questions, and her team have been looking at whether taking part in a weight management intervention, and such as those that we deliver out of Guy's and St Thomas's, can that lead to some people developing disordered eating, not necessarily anorexia or bulimia, but perhaps binge eating or so on. And so that's some research that's underway in our team. Yeah, and just one other thing. So I was thinking about this, people who do develop anorexia or bulimic behaviors who are living with a heavier weight, I think sometimes they're overlooked for treatment because they are heavier. So most people would assume that somebody who's living with anorexia, for example, is going to be, have a lower body mass index. So somebody who's much heavier but who has lost a significant amount of weight through that behavior is less likely to be admitted for treatment. There's definitely data that suggests that's true. So it is something to be concerned about. Thanks, Sarah.
Absolutely. No, I think it's really, really interesting, and just makes me think of working in bariatric surgery as well, sort of post-operatively, where people may develop kind of anorexia-like behaviors, but actually because of the excess skin, maybe wouldn't fall within the kind of weight criteria for eating disorder services. So that was really kind of a challenge that I did see on occasion. But really, really helpful insight. Thank you, Al. What about any practical advice? Now, so we've got a few questions just on some practical advice.
Yeah.
So what can people do to support their mental health when they are struggling with their weight or their body image?
Yeah, so this is a real issue, isn't it? So I think part of this is to do with the society that we live in now. So all the societal pressure from social media, for example. And so I think one of the things that the practical advice that I give to people that I see in clinic is to take a step back from social media if that's a problem, and of course to get support from the multidisciplinary team that's looking after you. So if you are within a weight management service, then seek support from those who are helping you. But if you are out there dealing with your weight and your body image yourself and not being part of an intervention, for example, then get support from people you trust. So if you can't get support from the multidisciplinary team, if you're not an intervention, then get support from people you trust to help you. I think one of the most important things is to practice self-compassion, self-care. And let me think. So, like a practical example of this would be to find some kind of physical activity to do that you enjoy. So it should never be a chore or a burden or a punishment. Something that's fun, you enjoy, could be something that you could turn to at that stage.
Fantastic. I can definitely echo all of that. And I think just with kind of mental health and the struggle with, weight, actually, I find that just in clinical practice, I suppose, the more focus there is on weight or shape, almost the more kind of our world restricts a little bit. So really trying to keep connected with things that provide you connection and enjoyment and, are you other than weight, I think is hugely important.
Thanks, Sarah.
What are the most effective treatments for patients with binge eating disorder or difficulties with emotional overeating?
Okay, so effective treatments. So I think this question is asking for results from research studies. But actually, I think just from my own practical experience, I think it's definitely individualized treatment from each of the members of the multidisciplinary team that might be looking after you. And for example, in the tier 3 interventions that we have from Guy's and St. Thomas's. But in terms of the research, I think mindfulness is the most commonly tested treatment. And there have been many randomized controlled trials looking at this from all over the world, and particularly looking at specific groups. For example, testing if mindfulness works in people who are living with severe mental illness, for example, or any other mental health adverse mental health conditions. And I noticed that there was a randomized control trial just published at the end of last year, so it's very recent, which was testing mindfulness in people with adverse mental health and excess weight. So in that study, the techniques that they were using were to explore so that people could be conscious of feelings of hunger and develop awareness of automatic processes so that they can intervene and stop those or pause them. And learning the relationship between eating and emotions. Thinking about some of the external triggers, the external signals to encourage you to eat, and comparing that to like physiological hunger. So actually, feeling the hunger, or is it just an external signal? There's lots of stuff around conscious enjoyment of eating, so being in the moment and being aware of the eating. There's so much pressure, isn't there, to wolf down food or to be looking at something else when you're eating. So I think combating that was also part of that randomized control trial, and just being more in touch with the sensations of excessive nutritional intake, so to know what that feels like and to be able to intervene at that point. So those were the kind of practical parts of the randomized control trial. So it was all of those versus like usual care or without that intervention, and it really did help treat with the emotional overeating and binge eating disorder. The other thing that I wanted to talk about was acceptance and commitment therapy, which I know is like a cornerstone of many psychological interventions in this space. And I know, Sarah, that's definitely something that you are an expert in, isn't it?
It is. Sorry. I think, yeah, in terms of the treatments, I suppose, particularly for binge eating disorder, I'd be thinking maybe sort of CBT, kind of cognitive behavioral therapy approaches. So it's in sort of nice recommended treatments, but we use a lot of acceptance and commitment therapy. And I was actually reading an interesting paper the other day that looked at kind of cognitive behavioral therapy versus CBT. Cognitive behavioral therapy versus acceptance and commitment therapy in weight management services for individuals living with excess weight, and found that actually the rate of weight loss with CBT was really good, but actually the long-term weight loss maintenance outcomes actually seem to be slightly better with acceptance and commitment therapy, which I think is a really important thing for us to be thinking about in our service, but also just on the journey of weight management, where we're wanting to make sure these are long-term sustainable changes, I suppose, that people can kind of embed into their lives. So some interesting research worth taking a look at.
Thanks, Sarah. And just to pick up on that point, it's so important to think about how we can help people with sustained behavior change, because it's extremely harmful metabolically and physiologically to experience weight regain after successful weight reduction, for example. That yo-yoing of weight loss and weight gain is extremely harmful in terms of mental health and at a metabolic level.
Absolutely. Okay, so I might move on to obesity and mental health pharmacotherapy, if that's okay for our next section.
We're going to talk about drugs.
Drugs. It seems people are talking about drugs a lot at the moment. Okay. So just to start off with quite a broad question, really, why would drugs be used to reduce excess weight?
Okay, so that's actually quite a good question, I think. And I suppose we have all, for many years, been reliant on lifestyle change, behavior change to help people manage excess weight. And of course, it really isn't as simple as energy in, energy out. I'm not saying that at all. The complexities of the obesogenic environment, the complexities of hormone signaling and genetics, it's fascinating. And I remember, when I was learning about this when I was a student, I couldn't believe the complexities of the pathways involved in managing appetite and weight. And of course, we only know a part of it. This is a fairly young science in the scheme of things, and there's so much still being discovered. So that's pretty exciting and useful, I think, to help people in the future. But behavior change, lifestyle change, although it does work for some people, it doesn't work for many. So I'm trying to think of some of the other interventions that have been used apart from pharmacotherapy, apart from drugs. So, for example, there's the total meal replacement intervention that's being used in the space for diabetes remission. So, in the DIRECT study. So that, for those of you not familiar, that's where you have, for 3 months, you replace all of your usual meals with meal replacement products that are high in protein and vitamins and don't have much else in them. So you consume about 800 calories a day, and that does deliver quite rapid weight loss, which is useful for mobilizing fat stores out of the pancreas and the liver, and in terms of diabetes remission, but probably not ideal for delivering longer term and sustained weight management. And so that's when, if we come to medicines, to pharmacotherapy, they can have a profound effect and long-lasting effect on reducing appetite. So in this field, this is where the GLP-1s, so those are the GLP-1 receptor agonist drugs that have been in the media a lot recently. These are the ones that have a profound effect on reducing appetite and can be used alongside behavior change to deliver significant and sustained weight loss for people living with excess weight. So, so these medicines act on if you think about how hormones within the body operate in terms of appetite, you can kind of divide it into 2 parts. So there's like chronic long-term control of appetite, and that's from hormones that are released from your fat stores, from adipose tissue. And then there's kind of like short-term immediate response to food that's eaten. And these are like GLP-1 hormones that are released in response to eating food. And this is the same pathway that these medicines, the GLP-1 drugs, work on. So they are being introduced. Of course, they're very readily available, and we'll talk about that later. They're very readily available on private prescription, not so easy in the NHS. I'm sure we'll have some questions about that later on if they're not already there. But I think it's important to say that these medicines don't work for 1 in 7 people. So 1 in 7 people have no benefit. So take these injections and don't experience that dramatic reduction in appetite. But when they do work, they can deliver fantastic results. So getting on for the level of weight reduction that you would experience from bariatric surgery, for example. But I do have concerns about how that happens. So from the research studies, these medicines are promoted to reduce appetite. And of course they do, but they also deliver quite a few side effects, particularly gut side effects. So I was in outpatient clinic this afternoon at Guy's speaking to one of my patients who had actually stopped taking the GLP-1s because he couldn't cope with the bloating and diarrhea and epigastric pain that he was experiencing on the medicines. And I do wonder if that discomfort does deliver some of the weight loss that we're seeing. But that's probably a pretty controversial view on my point, and I'm happy to be shot down on that. So just thinking again about why would drugs be used to reduce excess weight. It's interesting to think about what happens with some of the mental health medicines, for example. So there was a really good, interesting study from the United States, and I think this kind of study could probably only be conducted there because this is a study that was conducted on almost 3,000 people serving custodial sentences, so in the prison system in the United States, and where they keep very accurate records on all kinds of conditions. And so they had very accurate measurements of weight across people's custodial sentences, what medicines they were being prescribed, what was happening with their mental health, and so on. And what they saw in that study in the United States was that weight gain across the custodial sentence was significantly higher in people on mental health medicines. So that study really demonstrated that that is an effect, and that that weight gain was 3 times greater in women compared to men. But interestingly, in that study, there was absolutely no difference by ethnicity, which I thought was quite fascinating. Yeah.
No, I think that's super helpful. And obviously, it's something that comes up a lot, I suppose, just in kind of clinical practice, and obviously super important to take your mental health medications, but obviously important also to work with your kind of mental health teams or your GPs just to kind of see if there's anything else that can be done to support weight management alongside that. Thank you, Al. In terms of, I think you actually just touched upon it there, but the longer term implications, we got another question on what are the long term implications of people using semaglutide or other kind of similar weight loss drugs without proper support or supervision?
Yeah, so I have concerns about this. Certainly for people who are taking the medicines privately. So again, I remember one patient that I was seeing in a different clinic in the hospital who had been taking the medicines, the GLP-1s privately, and had developed some some difficult problems as a result that we only uncovered a bit further down the line. So there's an interesting paper published just the other week, I think 2 weeks ago, in Obesity Reviews, in that journal that you might all want to have a look at. So this was published by a researcher. She's called Jessie Richards from America, from Oklahoma, and it's quite a controversial paper. I think have a look at it. It's quite fascinating. So they asked the question: are GLP-1s too effective to be left unmonitored? And so the concerns are, as I alluded to, so malnutrition, potentially sarcopenia. This is where you're losing muscle mass at a greater rate. And we already earlier this evening we've talked about disordered eating and weight regain. So I think there are lots of concerns here, and certainly I think for me this really hammers home the fact that people on GLP-1 should be having multidisciplinary support.
I completely agree. We've had many, many, many conversations about this, Al. Completely agree with that. So just a few more questions on this. Interesting question on, is there any research relating to how people of different heritage might have different attitudes to pharmacotherapy?
Okay, so thinking about heritage, thinking about ethnicity. Yes, so a few studies from the UK, but again, mostly from the United States. So people of African American heritage in the United States, for example, are more likely to have concerns about their mental health medicines, and also have poorer adherence to them. So to be questioning about the medicines, and I think, I'm not surprised about this. So I don't know how many of you on the call are aware of the Tuskegee study. So this was the syphilis study that was conducted in Tuskegee in the United States. So what they did, this is going back about 60, 70 years now, was that they recruited people, servicemen, so airmen, into this study who had syphilis infection, and they didn't treat them. So they, basically the research participants weren't told. It was a very a terrible study, which has informed how we deal with research ethics. I know we're going to touch on that later on this evening briefly, but have a look at it. There's some really good videos online just describing what happened. So these were African American airmen, and they weren't treated. They were told that they had been treated, but they weren't treated, and so they went on to develop real complications from syphilis infection and passed the infection on to their wives, and then children were born congenital syphilis, and just awful, and nobody was told about it until I think 1970. That went on for decades. So I know, speaking to colleagues of Black heritage who live and work in South London, near where I work at Guy's Hospital, that people in the Black community in South London still talk about the Tuskegee study now and how that has affected their trust of the health service and taking part in research studies, for example. So I'm not surprised that the research then shows that people of Black heritage are more likely to have concerns about medicines for mental health. The other thing just to say is, so just to blow our own trumpet a little bit, is that we've had a paper published today in the journal Clinical Obesity. So you might want to have a look at that. And in that study that's published today, we showed that people of Black heritage lose weight on the GLP-1 liraglutide. They lose weight at a lower level compared to people of other ethnicities, and much more likely to cease treatment as well during the course. We don't know why yet. That's the next stage. So one of the next pieces of research that I'm going to do, along with Sarah's help, is to conduct research interviews with people to understand why there are these challenges. So why people are more likely to drop out from treatment with GLP-1s, to think about why people who are eligible for them decline treatment in the first place. And there certainly does seem to be a signal that this is more commonplace amongst, in the South London setting anyway, amongst people of Black heritage. And I just wonder if it's about this mistrust with the NHS, but I guess this research will show what happens there.
Absolutely. I think there was lots of interesting questions asked there as well, in terms of whether the rate of weight loss is maybe slower initially, but whether or not that kind of levels out to be kind of the same as other kind of white participants. But we definitely need to look into that more and think about how do we use that to tailor the care that we are providing and continuation data.
Yeah.
Thank you, Al. Okay, so I might actually then move that onto weight stigma as our kind of next section. I know that you could talk about this for days/weeks, so we'll try and keep this relatively contained. But we've had a question submitted asking if there's any research around whether the language we use, so i.e. the sort of the term obesity in itself, is stigmatizing. So could you tell us a little bit more about the research around the kind of language and weight stigma?
Yeah, you're right. I realise we're already at 20 to 8, and I'm probably talking far too much. So
Not at all.
shut me up. It's absolutely fine. Yeah, so this is an issue close to my heart. I find that weight stigma is all pervasive, and it's definitely, there's lots of stuff around language. By the way, if you want to see the effect that weight stigma can have, just Google the Belgian health minister. She was called Maggie de Block, so like a Flemish surname, so DE space Block, BLOCK. So Maggie de Block was um, uh, an amazing, highly qualified health minister. The Belgians were lucky to have her. It's brilliant, really clever, and so switched on to healthcare. And she was hounded out of her post because she's living with a heavier weight herself. So just have a look at that. And some of the stuff, the way it was reported in the media was really shocking. So, it's all pervasive weight stigma. And in terms of research, yes, there's some really great research looking at language. So I would draw everyone's attention to a paper in Obesity Reviews by the researcher Pool, Puhl. So that's from 2020. And it's all about how the language used affects how people feel about their health. So that's language from healthcare practitioners themselves, the language used in media, on television, you name it. So that's a really nice paper to look at. Also, our colleague, Professor Francesco Rubino, who works with us at King's Health Partners, he is a global lead in terms of obesity stigma. And if you're interested in this topic, please look at his paper that's published in Nature Medicine 2020. So he is working to create this consensus around using non-stigmatizing language in healthcare more widely.
Fantastic. Thank you, Al. I would definitely recommend reading Professor Rubino's stuff. It's very, very, very interesting. So we've also had a question submitted, I think, from a healthcare professional who wonders if there is any research planned to explore any negative impact on mental health of perceived pressure to take part in weight management interventions. That's whether actually taking part in these has a negative impact on anyone's mental health.
Yeah, so so these questions were submitted earlier, and I'd have a chance to look at them, of course. And so I've had a look round, and I'm not sure that I could find anything. If anyone's on the call who knows if there's any research in this space, would be really interested to hear, because I think it's a fascinating topic. And I can imagine the scenario where people are definitely pressured by, for example, their GP or their mental health practitioner to take part in a weight management intervention, and we know practically that it has to be the right time for that person, otherwise it's not going to work. And so I can imagine that pressure could be quite damaging and negative. So there is some research that's looking at this in a broader sense. So again, there's a paper that I would signpost you all to that's really interesting. This is from a researcher from Oxford, Rebecca Brown. I'm not sure if you're aware of her research, but this is a really great one. So from 2019. And she was looking at why women might be excluded from IVF treatment. So for those of you not aware, on the NHS, to qualify for IVF treatment, you need to have a BMI below a certain level. I think it's a BMI of 30 or less. And anyway, Rebecca Brown was looking at this, and in her research, she's posed a really interesting question. So she said, NICE coming up with this barrier of a BMI of 30 or less, are they judging people to be responsible for their own behaviors? So by saying you can't have IVF unless your BMI is less than 30, it's potentially like a systematic judgment in terms of stigma. And I thought, wow, that's a really arresting thought. A great paper to read if you're interested in that topic. I'd encourage you all to have a look at it.
Amazing. Thank you, Al. Okay, so again, whizzing through to different things. I think we might spend a bit more time now just talking about research and kind of practicalities taking part in research. So can you just explain a little bit about what a research volunteer could be asked to do in an obesity or mental health trial?
Yeah, thanks, Sarah. So, okay, so research trials, are extremely diverse. So, for example, it could be a randomized controlled trial of a new treatment versus usual care, or a new treatment versus placebo. So, for example, it could be for people living with adverse mental health, seeing if they respond to GLP-1s or a placebo injection, or it could be, for example, an intervention, so mindfulness versus usual care. And so, so really, it depends on the design of the study. It could be a study that falls under the umbrella of qualitative research. This is where you're interviewed and you tell the researcher your story around particular topics, and they'll have some prompt questions to ask you. So it could be any of those kind of things. I think it's really great to take part in research. I know the reasons why people take part in research are because you get better care. You get meticulous care when you're taking part in a research study that you may not get otherwise. So you're going to have a team of researchers, research nurses, doctors, and healthcare professionals who are going to be spending a lot of time with you in a very structured way according to a research protocol. So you may end up being seen, many times more frequently than you would on the regular NHS care, and that's definitely one of the benefits of taking part in research. So I did some work on this myself a few years ago. So I was asking research participants, why are you taking part in research? And some of the common answers were, I guess it's evident. A lot of people said altruism, so to help other people, to help society, to help people with particular conditions. And so that kind of mention of altruism was very common. But some people were very honest. I'm taking part in research myself because I want to get the best care I can, and also people wanting or hoping for better outcomes with a new treatment, for example. Yeah, so I think it's important to take part, and you can get real benefit.
Absolutely. And I think that was actually our next question, Al, of what are the benefits of taking part in obesity and
Okay.
mental health research? So that ticked that one off as well. Perfect. Thank you. So the next one is just a little bit of information about what materials do you provide to your research volunteers to help them understand the aims of your research?
Okay, so a good question. So every single research study has a participant information leaflet, which will explain in great detail what the study is all about, what you'll do if you take part, the risks and benefits, and so on. If there's any financial reward, for example, covering expenses of traveling to the research site. So every study in the UK, it will provide participants with information like that, even the smallest ones. So, for example, if some of the small studies that I've done in the past, where I may end up interviewing a handful of people or running one or two focus groups, it's still important to give as much detail as possible in those information sheets. However, some of the larger studies that have more resources or more money available produce animations and videos that you can watch that explain the aims of the research, what's going to take part. So definitely depending on the resource of the study, sometimes there's some great things. And if you look at the Be Part of Research website that I talked about at the start, and for those of you who joined midway through, if you just use the search engine to look at Be Part of Research, you can look at some of those larger studies, and when you click on the what's involved, they'll take you to some of these amazing websites with animations and videos and things.
Fantastic. So that actually, again, is the next question of how does
Oh.
someone find out about research within that? You're reading the questions.
Sorry.
Within their local NHS trust or GP practice. So they can obviously go to any other kind of routes of finding out about research.
Yeah, so I think just ask your healthcare provider. So, ask your GP, are there any research studies taking part at the moment here that that I could might qualify or might be eligible for on the website. So most GP practices have a decent website these days, and there'll definitely be a research taking part in research section there, and also, of course, for hospital trusts, they all have taking part in research parts of their website, so you can have a look at that. So if I've got time, Sarah, I did have a look at the Be Part of Research website earlier today, and I
Right.
was looking at if there was anything available for people living with adverse mental health and excess weight. And I found two quite diverse, different, studies. So there's one called Empower One, so Empower, Empower, Empower One, which is a global multinational cohort study looking to reduce health inequities. Seems fascinating, and they're recruiting thousands of people into that study, and it's to really explore people from different backgrounds who sometimes are excluded or don't get ideal care, to just follow them through a whole range of conditions, including many mental health conditions and heavier weight. So that was quite an interesting one. Have a look at that one, Empower One. And then the other one that I saw on BPART Research was a study investigating a new device for blood pressure, for hypertension. So this one is actively recruiting people who are living with adverse mental health. And if you take part in that study, you're given this new device that you attach, and it stimulates nerves in your body. So it gives you these impulses that are they're testing whether that's going to control your blood pressure. Just to say, one of the drawbacks of living with an adverse mental health condition is that, unfortunately, a lot of research studies exclude you from taking part because of that. 1 day a week I work in the HIV clinic at Guy's, and again, for people with HIV, they're often excluded from research studies. And then old codgers like myself, age is often an issue. So now that I'm past the 60 threshold, I can't take part in many research studies as well. So there are quite a few barriers, and unfortunately, living with adverse mental health it makes you ineligible for quite a few research studies. But if you look on the Be Part of Research website, it lists all of those, and you can see which ones you're eligible for.
Perfect. And I think that touches on actually some of the examples of kind of what research is out there at the moment and what can we get involved in. So that's fantastic to hear. Just, I think, with the final kind of research theme, just after us talking about safety and kind of maybe some nervousness about engaging in research, completely understandably.
Yeah.
So a question we have had is, is it safe to take part in research, and kind of how are clinical trials regulated? So just touching on that.
Yeah, I'll be really brief. I think
Yeah.
it's incredible how well research trials are regulated these days in the UK. I think we have one of the safest ethical control systems. It's just brilliant. It does make it quite hard work for us researchers, but
It does.
quite rightly, we need to be
Yeah.
accountable. But it's really good, and the trial has to be approved by an NHS ethics committee, and on that committee are lay members, so people who are not researched as members of the public. And anyone who wants to volunteer to be part of an NHS ethics committee, please do. It's a great role to have. Then once the trial's up and running, there are committees who oversee and make sure that everything is safe. Any adverse events that take part within a research trial are reported to that committee and are examined. And I remember when I first started out in research many years ago, I was puzzled as to why certain things were classified as an adverse event within a research study. So, for example, if you were conducting interviews with people about how they felt about their GP, if that was the research, and one of the research participants fell over and broke their leg, you would still have to report that as an adverse event. And you think, well, what on earth has that got to do with this research study? Because we were doing interviews about how they felt about their GP, but you never know. It might be something related. Perhaps they had anxiety about something and they weren't watching where they were walking or something like that. So everything gets reported and monitored, and I think it just makes it all really safe.
Perfect. Thank you, Al. I think we are coming to the end of our questions, so you can breathe,
Yes.
which is nice. I've just noticed, I've just been monitoring the chat. So it looks like there's only one question in the chat so far, which I don't know if you would want to answer now, would want to answer kind of later on, but it's just asking about your approach for working with service users who have schizophrenia and diabetes. What is the evidence based for the best approach?
Okay. I think we're gonna have to leave that question because it's definitely something that I'd
It
want to
probably,
go away and have a think about. I think.
absolutely, it
Yeah.
might be a
Yeah.
long thing. So
Yeah. Yeah.
before we finish up, I think just maybe finishing on, do you have a favorite career highlight of working in obesity and mental health research?
Yes, I think I do. Thanks for whoever posed that question. I think it's been an absolute privilege for me to conduct some of the in-depth research interviews with people living with a heavy weight and adverse mental health. Spending that time with somebody exploring their story and their experiences, and sometimes, you know, the research interviews can be pretty long. So some of the interviews I've conducted with people in that research setting have lasted for the best part of 2 hours, and I'll never forget. It's genuinely a privilege. I'll never forget what many of those research participants have told me in those interviews. I'm sharing challenging life stories, some of them very funny. I remember what one guy saying, who's living with a heavier weight, telling me, if I looked in the mirror, would I ask me out for a date looking like this? No, I would not. Please help me lose this weight. You know, so quite funny. And then some of them terribly, terribly poignant and sad as well. Also kind of ending up being another really amazing thing was ending up being an unintentional anthropologist in a way. So I remember doing some research interviews about body image, and I was interviewing a couple of gay guys who were living with excess weight, heavier weight, and they identified as part of the gay bear community, which I didn't really know about before. So these are gay guys who are bigger, tend to move away from the gay scene, where there's lots of issues around being fit and thinner, and you know, all of that side of things. They were talking about being part of this supportive community, and being loved for living with a bigger body, um, and saying things like, you know, this helped me get over my anxiety about being judged on the gay scene, you know, about being a bigger guy, and it was really, really moving and really interesting, and something, you know, learning something completely new was great. I absolutely loved that bit of research. It was fantastic. And also, if I've got time, Sarah, I just want to say about the service development research that we've done in Lewisham. So a project called Up, which is just amazing. So this is a weight management intervention, not specifically for people living with adverse mental health, but co-designed for people from the Black African, Black Caribbean communities in Lewisham. So working with those communities to develop a weight management intervention, and that was just amazing. Great being part of that, and also just to hear people saying, please don't talk about weight loss. We're not interested in loss. We want to talk about health improvement. And so that's why the program's called Up, which is Jamaican for getting better and improving and being better. So a fantastic program to be part of.
Absolutely. Thank you, Al. And I definitely echo that. I think all of the feedback and service user kind of events that we do, I just find them so helpful and so enjoyable. Thank you, Al. I think that kind of brings us to the end of
We've run
our
out. Was there nothing in
questions.
the Q&A apart from that one
There was
question?
nothing in the Q&A, unless
which
anyone.
no, I will try and
Yeah.
answer that question tomorrow when we got more time. Yeah.
If anyone does have any kind of, you know, questions that they do want us to ask or answer afterwards, please do post them now. We can kind of get to those in the after bits. But thank you, Al, and thank you everyone for providing all of the questions beforehand as well. I think it helped a very insightful and informative session. I certainly enjoyed it, so I hope you did too. And thank you to our hosts, the NIHR, for organising the event. And as Al said many times, if you want to learn more about the research or to take part in any of the studies, then search for Be Part of Research website on any kind of search engine. And remember that you can take part in that even if you're not living with a kind of specific health condition. And just the final kind of formalities we reiterated at the start anyway, but you'll receive a recording of tonight's event and an evaluation form. So please take a moment to complete that. And we want to run more of these events, so it's helpful to get kind of feedback and see what we're getting right and what we could improve. Al, have you got anything to say before we finish up?
No, just thank you, Sarah, for posing the questions, and more importantly, thank you to everybody who's joined this evening. Shame we can't see your faces, but it's been great having you here, and I hope I've gone some way to answering some of the questions that you've posed.
That was amazing, Al. Thank you very much. In that case, we will finish the webinar off now with 1 minute to spare, and enjoy your evenings, everybody. Thank you so much for joining us. Bye.